Good morning. It's my pleasure to welcome you all again on behalf of the Malone Center and the Armstrong Institute to this next segment of the program. We're introducing the lightning pitch segment of the program, which, as Greg alluded to in his introduction, is an opportunity to hear some voices from the broader community that align with this year's symposium's topic and theme. And so we've asked all the participants to specifically come with questions and requests to this diverse audience, and we would welcome your feedback with questions. We'll have time approximately for 1 or 2 questions after each very brief presentation. So with that, I'm going to go ahead and introduce our first speaker. It's LILIANA STEFANIUK, Practice Manager at Glen Burnie Medical Center. She's going to be presenting a concept of cloud-based electronic health records for limited English proficiency in international patients.
Good morning, ladies and gentlemen. I think for some people still morning. So for the past 30 years, demographics significantly changed due to the rising number of the immigrants in the United States. Just between 1980 and 2015, the U.S. minority population increased by 29.2 million people. Just think about it. 1 in 5 people speak other language than English at their homes. 1/3 of the entire U.S. population is considered as limited English proficiency population, which means they speak English less than very well. On the other hand, medical tourism is one of the fastest growing sectors of the global economy. LEP and international patients are at higher risk of adverse events due to the language barriers or cultural differences comparing to their English-speaking patients with the same medical conditions. Difficulties in understanding instructions for prior or post-surgery medical treatment, lab test results, or medication can lead to the surgical delays, to the readmissions, medical errors, and hospital longer stays. As a result, it increased hospital liabilities and risk management according to the risks that we have with surgery delays and readmissions. So I would like to represent you a concept of 1L. It's a cloud-based system that is available for smartphone, tablet, and PC users. It's available in any language that is requested and the stakeholders fluent at. So international patients would be able to upload their digital records and all their information, and the U.S. healthcare provider would be able to get it in English or any other requested language. As a result, the system works vice versa, so which means when they finish their treatment in the United States, they would be able to come back home and release their medical records to the local healthcare providers in the language that they're fluent at. In terms of medication, they can indicate what kind of medication they were using in the United States or overseas, which means 1L as an analytical tool would be able to indicate it and show the equivalent of the US or the local medication. The goal is to create and implement and adopt this system that will be available for all LEP international patients in any language that is available or they're fluent at. As I'm not a software engineer or IT guru, I would need help of the team of software engineers, IT specialists, and other team. I hope this application will help to improve quality of healthcare services, improve patient safety, and minimize communication gap. Thank you.
Are there any questions? Yep. Our next speaker is Erin Hsu, a clinical research assistant in the anesthesiology and critical care clinical research core. He's going to be sharing his concept of ClearMask, a non-fogging transparent mask that he'll tell you a lot more about.
Hi everyone, my name's Erin and I'm here to talk to you about ClearMask, but before I do that I want to talk to you a little bit about the problem. And the problem is that medical errors are the third most common cause of death in the United States, and obviously that's unacceptable, and as you can see it's a major problem. And miscommunication is the leading cause of medical errors, and it's pervasive throughout the hospital. It's not just in surgery, it happens in general medicine, it happens in obstetrics, it happens on the floor with nurses. And it's not just between providers either. It happens just as much between patients and providers. And so the question we wanted to ask was, how can we improve communication in this setting? And the answer came to us about 2 years ago. My girlfriend had to have surgery, and she's deaf. So we had requested a sign language interpreter. On the day of surgery, we show up, and the interpreter never came. We didn't want to delay the surgery, and so she got by just by lip reading, seeing facial expressions, and visual cues. But once she got into the operating room, everyone around her was wearing a face mask. This made it impossible for her to communicate. She couldn't lip read, she couldn't see facial expressions. They were trying to ask her questions, they were trying to talk to her, give her instructions, and she had no idea what was going on. In one of the scariest moments of her life, she was completely cut off from everyone around her. And this is a problem for a lot of people. As a deaf person, Alyssa understands how important visual cues and facial expressions are in communication. It accounts for 55% of our communication. And it's not just for deaf and hard of hearing people. We all use visual cues, even if we don't consciously realize it. You know, it's in our subconscious, and it's not just to communicate what we want to say. It's also to communicate our emotions, our empathy. Research has shown if you can't see a person's face, you have no idea what they're really thinking. And this is a big problem. There are 48 million deaf and hard of hearing people in the United States, and facial expressions, visual cues, and lip reading is critical for their understanding. Beyond that, 25 million people with limited English proficiency that need this facial expression and visual cues to supplement their understanding. And it's not just communication. You know, there are a lot of children, 74 million children, that are scared of going to the doctor, of going to the dentist. These children need to see facial expressions. They need to see the smile from their doctor. They need to understand that the person behind the mask is there to care for them. That's why we came up with the ClearMask. It's the first full-face transparent face mask that is comfortable and does not fog. We are conducting clinical trials and submitting a grant to help with our clinical trial. So if you're interested in piloting the ClearMask or doing any research, or you have some questions, or just want to help us in general, please come talk to me after this presentation. Thank you for your time.
Erin, do you want to come back? I think there's a question.
Asking you a proprietary question. What's it made of?
I can't say, I'm sorry. I actually have a competitor sitting in the audience right now.
I would certainly encourage you to find him after the presentation during lunch. Our next presenter is James BRASIC, an assistant professor of the Division of Nuclear Medicine and Molecular Imaging here in the Department of Radiology. He's going to be presenting a concept about quantitative continuous measurement of resting state functional magnetic resonance imaging and movements in people with Parkinson's disease.
We seek to develop a team, including technologists and care providers, to develop instrumentation to facilitate the diagnosis and treatment of people with Parkinson's disease and related conditions across the care continuum. Parkinson's disease is the second leading neurodegenerative disorder. It's the 14th cause of death. 60%, 1% of the population above 60 are afflicted by Parkinson's disease with symptoms of slowness of movement, tremor, and rigidity. The diagnosis is based on the history and examination. A rating scale has been developed to observe people when they are asked to perform procedures that bring on the signs of Parkinson's disease. This is subjective and it depends on the skills of the examiner. Therefore, we have developed instrumentation to give a quantitative representation of the movements of people continuously while the rating procedure is being instrumented. So the tool that we're using involves having an accelerometer. That's a device that represents the 3 dimensions of the device in space. This is placed on 4 extremities, and it's connected, the output is connected to a data logger that then goes to a computer. And through a programming, the representation of the movements is expressed in space. We seek to develop this currently to utilize during radiologic procedures, particularly magnetic resonance, because that has demonstrated some subtypes of Parkinson's disease. So in addition to this procedure, we aim to have the person within a magnetic resonance scanner at the same time. A problem is that we need equipment that is not magnetic, so we need the help of individuals to develop compatible equipment. In order to test our device, we have sought the help of a healthy man without Parkinson's disease who is familiar with the condition, and he simulated tremors of varying severity while this procedure was administered. The output showed that, in fact, there is a continuous tremor, and the severity is, the amplitude of the voltage is proportional to the severity of the tremor. Note that even without a tremor, there is a fine tonic movement. So we healthy people do have movements. There is a very fine tonic movement that's present in each of us, and it's exaggerated by people who have Parkinson's disease. And using fast Fourier transforms, we're able to display this. Therefore, we seek the help of engineers, technologists, to develop a magnetic resonance compatible form of this device.
Quick question, how far along in this process are you in terms of the development of the clinical application of this?
We are conducting a study for over the past year, and we've tested around 18 people with Parkinson's disease. We've done retest on a couple of them, and we're also looking at people who have atypical Parkinsonism. So these have some symptoms but need to be differentiated from the patients themselves. So we are conducting a study approved by the IRB to assess this procedure. And the device actually appears to pick up subtleties that are not detected in the clinical administration of the procedure. So there does seem to be some benefit to it, where we think that that's something that can be further developed.
Our next presenter is Michelle Calder CARRAS, a postdoctoral fellow in Psychiatric Epidemiology training program in the Department of Mental Health at the Johns Hopkins Bloomberg School of Public Health, presenting a concept about translating internet interventions that was developed in a multidisciplinary team.
So our concept comes out of a question that was raised at a discussion section at the International Society for Research on Internet Interventions. Why do we keep using the word depression? None of our patients do. With user-facing interventions, it doesn't matter how good your intervention is if people don't use it, either because they don't think it's relevant to them, or worse, they don't even realize it's for them in the first place. Language is key. When we say depression, we know that someone else might say low energy or struggling. So what if we could predict the kind of language that's most likely to be understood for an individual and ensure that those are the words that the person sees first when they navigate to the intervention or when it's presented through an advertisement, and that continues as points of familiarity throughout their interaction. And practitioners do this already when they pitch a treatment to a patient or follow up and see how things are going. But how can we bring that capability to internet interventions when there's no human in the loop? Well, we think there are three ingredients. We need a way to identify the kinds of language used that are likely to resonate, a way to map those terms to an individual, and a way to integrate those into an adaptive intervention. But where could we identify the language used and the predictors? Social media is an obvious choice. We could build on the expertise that we have in this room to parse data from social media about demographics, health literacy, interests, etc. And then we could use that language and those predictors to develop analytics that would give us a way to target interventions with a Mad Libs or fill-in-the-blanks type approach that populates the type, order, style, and intensity of the language and content. So if this were to work, what would this mean for a user in 5 years? Meet Jane and Frank. Both have clinically relevant depression. Neither has sought help. For Jane, the predominant symptom is feeling immobilized by a bad mood. For Frank, it's just a feeling of stress or having too many problems. Where at one time they would see this, now each gets a tailored experience. Our team has expertise in clinical and public health informatics, psychology, and psychiatry, but we would need to collaborate with engineers and computer scientists on this project, and of course, we need funding. Step one would be to develop candidate set of language for some target populations, and we could probably handle that with our team, but then step two would be to recruit people from social media and fine-tune the analytics using a variety of features to help us develop this fill-in-the-blanks approach. Finally, we would need to collaborate to develop an actual platform to use to adapt interventions with this language. Thank you. This is super exciting to be here.
Michelle, can I ask a question? Is there a particular area within health? Are you focusing on mental health specifically?
We're using depression as the use case because it's very simple to understand the differences and how people would talk about it, but we think this can be applied for many different use cases. Thank you.
Our last presenter is Stephen Klein, systems engineer and graduate student at the Whiting School. He's presenting a concept about the approach and benefits of a patient-centric medical record storage and access system. Stephen, please.
Good morning. My name is Stephen Klein, and I'm a graduate student at the Whiting School of Engineering, and I'm pleased to be sharing with you my ideas. For the past 2 years, I've been researching the problem of medical record data transportability, how it is controlled, how it is accessed, and how it is secured. Medical record data is the most personal type of data. It gives a story to the essence of what it means to be you, an individual. Every individual is a dynamic, mobile person being able to go where he or she wants to go over the course of their life. Our medical data is not as flexible. We can conceptualize medical data transportability in 3 words: access, security, and organization. Currently, medical data is stuck in silos of your hospitals, physicians, and clinics. It takes days or weeks to collect your collective medical data. Gaining access to your data even comes at a serious cost in time or money to both you and your provider. So right now, we have limited access in various levels of security across your providers. The system that I have been designing allows individuals to maintain security over their data by easily controlling encryption keys to your collective medical information. When the patient wants to provide the physician with his or her medical record, he or she can now provide access. However, unless the patient controls the keys to encryption, the patient is not in control of their own data. Since the data is encrypted, it can now be stored anywhere because no one can gain access to the underlying patient information. Using modern technologies such as blockchain, we can easily, simply, and anonymously organize medical data. Now we have achieved access, security, and organization. Why should we do this? Because it seems like a lot of work, and it is. Once we organize medical data and allow the patient to control who has access to it, we can then voluntarily bring that information together, allowing more people to address preventative and predictive medical issues. Significant time usually lapses when we can measure molecular change. Then symptoms arise, and then we ultimately seek a doctor's expert opinion. My vision is to create a system for patients from around the world to voluntarily allow a math student from India or a physicist in Japan to have access to the world's collective anonymized medical history and develop predictive medicine tools. It should not be siloed by any organization. Instead, the only limiting factors should be the individual and the world's collective brain power. I'm ready to finish my research and move into development, and I'm looking partners to do this. Thank you for your time.
Stephen, are there any particular skill sets that you're looking or other pieces of research that you'd like to find in the audience?
Well, investors is always probably the first thing, but most importantly is really experts who have knowledge in blockchain or encryption or just who have a real passion for this. And I think that's the most important thing is that we need change in this area, and that if there are engineers out there who want to be a part of this, I'm absolutely willing to entertain that. So thank you.
Great. Well, thank you very much, and I would welcome all of our audience to reach out to these individuals to learn more about their ideas and hopefully stimulate some good conversation during lunch. With that, I'll turn it over back to Greg if there are any other closing remarks.
Great. Thank you. My only closing remark right now is it's time for lunch. And I think you've all deserved it. You've been a great audience this morning. Lunch is just through the doors here. You can pick it up on the way through. If you have any special dietary needs, you'll have to ask a server. We do have some kosher meals and some gluten-free meals, too, if you ordered those. So with that, please go, enjoy, have some conversation, and we will herd you all back here at 1 o'clock for our next panel.